now.
Good morning, everybody. Welcome to today's session of Changing the Way We Work. I'm Eleanor Colledge. I'm a family physician. I work in East Toronto and I'm the CPD program director at the Department of Family and Community Medicine. Really delighted to be moderating today and also happy that we can continue to bring you these sessions in conjunction with the Ontario College of Family Physicians. And I'm going to turn things over now to Dr. Jobin Varughese to introduce the session.
Thanks so much, Eleanor, and welcome everybody. And we're thrilled to be able to provide this session in concert with the DFCM. Next slide. Just a quick heads up, I'm going to have Eleanor and everybody introduce themselves, but I just wanted to state that the Changing the Way We Work community practice is a 1 credit per hour group learnings program and been certified for 32 credits. The previous credit issues have been figured out, and so we'll be submitting that based on your application. Next slide. One of the really important things that we are proud to offer is the fact that some people we know review this as a asynchronous virtual offering, and so you can have credits afterwards. So please feel free to click the button there that you see on screen, the completed self-learning credit, where you can earn credits for this session if you watch it afterwards or past sessions. Next slide. I'll complete a quick land acknowledgement and do a quick reflection as well. We acknowledge that the lands on which we are hosting this meeting includes the traditional territories of many nations. The OCFP and DFCM recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I just take a moment to reflect on the fact that both of our topics, both the TB talk and thinking about financial security, can both be tied very closely to those of the Indigenous people. And so I do think that we want to think about where we can embed the things we learned today into how we have our conversations with our patients, both in a clinical sense, but also a culturally safe sense, how we can think about how it affects us professionally or personally, and how we can collectively come together as a group to advocate for pathways that help equitable support for all people who are underserved or those that are having problems with these areas. So I put that as a quick reflection and something to think about for each of us as we kind of gain knowledge here today. And I thank you, and I hand it back to you, Eleanor.
Thanks very much, Jobin. And I'm calling in from the territories traditionally used by the Wendat, the Anishinaabe, the Haudenosaunee, the Mississaugas of the Credit, and the Chippewa. Just a reminder that our session today is part of a series, all of which are available online. And we have a scientific planning committee that reviews all of our content to mitigate bias and also runs things behind the show to make sure that everything goes smoothly. So always a big thank you to them. Next slide, please. So delighted at this point to introduce our panelists. I'm going to ask each of them to introduce themselves and speak to their conflicts of interest. So next slide, please. Dr. Zain Chagla.
Hi, Zain Chagla. I'm an infectious physician from Hamilton. My conflicts are here. I'm Merck advisor for industry-sponsored trials and a Speakers Bureau and honorarium from a number of companies and an honorarium for today.
Great, and I'm Mark Soth. I'm an ICU physician practicing in Hamilton, and I also spend a big chunk of my time teaching physicians about personal finance, investing, and financial wellness. I'm not a financial professional. I don't get paid to sell products or anything like that, but I do have a blog, looniedoctor.ca, and a podcast, the Money Scope podcast, that I use to provide curriculum to people. My blog, it does have sponsorship by BMO ETFs, PWL Capital, both of which do provide financial services. And I have an affiliation with Qtrade Direct Investing, which is a DIY investing platform that people can use.
Thank you very much, Mark. Turn things to you, Jobin.
Yeah, thanks so much. And just to, as a quick aside for the mitigation of bias, the Planning Committee have reviewed the slides to ensure that bias has not been inserted into the talks. My own slides are disclosures are that I'm the president of the Ontario College of Family Physicians. I also have a role with the TMU School of Medicine as interim assistant dean of primary care education, and William Osler Health System as the associate vice president of academics. Thanks.
Thanks very much, Jobin. And I've already introduced myself. I do receive an honorarium from the OCFP, as well as for some work that I do with the Foundation for Medical Practice Education, neither of which pose a conflict for today. Next slide, please. So just a reminder, if you've never been on our session before, just that if you want to post a question, please put it in the Q&A. And if you see a question there that you want to have answered, then please upvote it rather than writing it again. That way I know which ones to prioritize when I'm asking our speakers. And then, of course, please feel free to use the chat to say hello, share any knowledge or resources that you're bringing to the table here, which is one of the wonderful things about this community of practice, and do any general networking. Next slide, please. We'll get started in a moment. I just wanted to lay out the schedule for this morning. We're going to start with Zain, who's going to give us, going to be speaking with us about TB testing. And then we'll break for questions and then turn things over to Mark to talk more about the opportunity for pension plans and some financial planning. That's next slide, please. Great. I'll turn things over to you now, Zain. Thanks.
Hi, everyone. Good morning, and thanks for having me. So today's focus is going to be around latent TB testing. I'll go through just a quick update on what's going on in the landscape and then have some time to take questions. Next slide. So we'll briefly go over kind of the spectrum of TB disease. I will describe the tests for latent TB and kind of their outcomes, how to counsel around a positive test, and then finally active TB and precautions, just as an aside for those who do come into contact with individuals where it's suspect. Next slide. So just as an update of what's going on in the community in terms of respiratory viruses, markedly down with some low level of COVID activity that is going through the summer, but seasonally things came down. Fairly prolonged influenza season, which even went into the early bits of May, but are now settling. In terms of what's going on with measles, and not going to go through this significantly, but the outbreak is improving significantly in Ontario. There are some sporadic travel-related cases showing up, but otherwise smaller numbers as compared to weeks ago. And I think the epicenter now is kind of north of Waterloo. And then the major infectious disease issue, I think that's been declared in London, Ontario, and there's a map here of the area that seems of concern, is a number of cases of Legionella that have been described, including 2 deaths, and I think about 68 cases. There doesn't seem to be a common link, although with Legionella outbreaks, there usually is a common link of some sort of water-based ventilation system. But the area of London here is on the map. If people need a larger resource, there's a couple of articles to Google, and the Middlesex London Health Unit has the map. But in individuals in this area who kind of come in with atypical pneumonia or fairly significant pneumonia may need to be considered as part of the differential diagnosis, given this outbreak is ongoing. Next slide. So going back to tuberculosis, back to first principles. When one inhales Mycobacterium tuberculosis, the bacteria, usually through someone else coughing it and putting it in the air, the bacilli go down to the lungs. About 5% of people do get a primary tuberculosis syndrome, where that can present almost like a pneumonia. It's more common in people immunocompromised and children under 5. But the vast majority, their immune system will wall it off into a granuloma, where it remains in the upper lobes due to the ventilation perfusion mismatch, so less perfusion and high oxygen capacity, and remain latent there for some time. The estimates from a global standpoint, used to be about 1 in 3. It's probably 1 in 6 to 1 in 7 now. that really reside at this state where they have chronic granulomas from old tuberculosis that is now in their upper lobes. And so, this is what we talk about in terms of latent tuberculosis testing. And then, the reasoning is that although 95% of individuals will stay at this state, about 5% may progress to cavitary TB, where the TB then is able to invade their body, especially in the upper lobes, causing cavities, but also cause other significant morbidity. And that may also be modified by their underlying immune status, other disease states, sometimes even things like silica exposure. And so, really looking at TB testing as a method of detecting some of those cases and potentially offering treatment to reduce the risk. Next slide. So why test? One is occupational health requirements is probably the most common reasoning for testing, and many organizations do this. And the hope is that you identify individuals at risk for activation of TB in the healthcare setting where they may infect individuals that are at much higher risk of then having disease. And so, many of us have had at least one TB test through our training, and again, is still a requirement for certain settings, although is really being narrowed down in terms of some settings in the higher risk for TB exposure. Pre-immunosuppression, which is obviously for consequences of the immunosuppression in tuberculosis, and then some other high-risk settings in dialysis, for example, in indigenous health settings where there are cases, in post-exposure outbreak settings, in homeless sector, especially in individuals that quite frequently interact with the jail system where there's a significant TB burden, and then in certain congregate settings, especially again as people enter. The question outside of these settings is who to test, and the general rule of thumb is where we think treatment would benefit that individual and it would be offered. And so, I would be cautioned to say every person, for example, from a TB endemic area of the world requires TB skin testing. They likely don't unless they fall into some of these settings or, have some other social or other risk factor. And certainly if you're not going to be having a discussion around TB therapy for that individual, then you probably shouldn't be testing that individual outside of, again, some of these more regulatory requirements. When not to test, and the big thing is ruling out active TB outside of certain unique populations like children. And the reasoning there is people may be exposed to TB that could increase the risk of active TB. So when you're thinking about active TB, yes, they may have a positive latent test, but active TB often involves, especially in healthy individuals, an anergy. Their T cell response doesn't work well. And so they may, and have seen many, many cases where their TB skin test is actually frankly negative and they have fairly profound active TB. And so it is not a good rule out test in this setting. Again, outside of certain settings where it's hard to diagnose TB, where it might be used as a part of a scoring system. Next slide. So the TB skin test is the injection of purified protein derivatives. So this is a cross-reactive antigen that cross-reacts with BCG. It's done intradermally. So as I was taught, just under the first layer of the skin, no further down. So you really should be seeing the end of the needle. Anything subcutaneously is considered an inactive test. And this looks for an in vivo response to T cell to TB antigens with T cell. So again, the wheel that forms essentially is a delayed hypersensitivity reaction to the TB antigens. It's read at 48 to 72 hours, and we measure induration. Well, I just have a diagram in the next picture to show you that. It can be affected by immunosuppression and give you a false negative. It can also be affected by the BCG vaccine and give you a false positive, typically if it's given at greater than a year of age. And some of us have requests for two-stage skin tests, and this is just a one-time phenomenon where people may have had exposure in the past. Their first test is negative, but that first test actually triggers their immune response to remember the TB antigen again. And so if you were to do a test a week or two later, it would be actually positive. And this is why we do the two-stage. If you didn't do the two-stage in this setting, their next test would essentially be positive. And so it can actually give you a false positive result on the next test. For example, if I were to do a one-stage this year and then a one-stage next year, my one stage next year would be positive, and all of a sudden we say, oh God, you got exposed to TB in the last year, where in reality it was a false positive test because of the fact that your body just needed to wake up to the TB antigen. Only done on first test. So the first time someone asks for testing at 2 stages is there. But after that point, if they have a documented negative TB skin test, a documented negative 2-stage TB skin test, that 1-stage tests are fine for people that have serial needs. Next slide. So again, the injection is, essentially, again, 1 layer under the skin, 1 layer of cells under the skin, and we're marking the area of induration. The pen test is actually what I love the most. So again, where the bump is. And so, essentially run the pen along the skin surface where you start feeling resistance against the pen, stop, go, immediately opposite to that side, do the same thing, and then just measure the difference between the 2 pen points. I find using human touch sometimes is a little bit trickier because you don't feel that resistance as well, especially because the palms of your fingers, so the pads of your fingers are quite wide. And so, if you're doing this, use a waterproof marker and clean the skin after, but it actually, for me, actually just gives you a nice zone, and then you can just easily measure between the 2 lines. Next slide. So these are the cutoffs from the TB standards, just as reference. So, anything less than 5 millimeters is considered negative. Between 5 to 10 millimeters, people that are considered immunocompromised or have underlying conditions that put them in higher risk, including recent contact or evidence of old TB changes, or on X-ray, would be between 5 and 10. And then, everyone else greater than 10 millimeters would be considered a positive test, particularly for even populations considered at low risk of disease. Next slide. So the next test is the interferon gamma release assay, or the IGRA. And essentially think of this, rather than having an in vivo test, i.e. using the skin and the T-cell response under the skin, you're essentially doing it in a vial. And so you're taking the patient's blood, you're adding antigens that are a little bit more distinct from BCG, which is one of the advantages here. And then you're just incubating it and looking for interferon release from the patient cells, which then, is essentially the same thing as what's happening in the skin, causing that inflammatory response. Rather than measuring the induration, you actually just measure the interferon. This is, similar, and we'll talk about where to use one or the other. There are some issues with blood storage and draw, so you have to do it first thing in the morning, and you need fresh blood and to be able to get the white blood cell coat out of it. And there may be some storage. There are occasionally assay issues where the controls unfortunately don't work well. This is currently not funded in Ontario, although there are some rumors perhaps this may change down the line. It's about $104, and it has to be booked online because of the timing requirements in certain labs that are able to do the transport. And so if you have a patient that is interested in this, or you think this is the better test, make sure they go to the Life Labs or DynaCare website, find the requirements, find the lab in their area that does it, understand the cost, book an appointment, because all of those need to be done before the IGRA can be done successfully. If you go at the end of the day, it won't be able to be done successfully. This can be filled out on an OHIP rec. There may be occasionally other documents that need to be signed. And it is important, worth asking the patient, especially for biologics. I find sometimes the companies are willing to actually fund this to help with moving people through the biologic process. And so it may be worth it for especially people who are using capacity programs through the drug, that they can ask the company for IGRA testing as part of their workup. Next slide. So which one to use is a big question. Either is pretty good for most individuals. There is, a slight advantage to IGRA for those who have had BCG, especially in 2 to 10 years, even if they've had it at birth. If they're between 2 and 10 years of age, they may still get a false positive PPD. If they're over 10 and had BCG over a year of age, where they still may get a false positive test, again, under a year of age and over 10, likely if a positive result happens on a TSD, it's truly a positive. But if BCG is given over a year of age, people can have false positive tests, and so it's worth it to do. A lot of people have uncertainty of where they got BCG, depending on where they are in the world. And BCG Atlas is actually a great resource that can help to kind of look at policies over time, and so you can kind of get a sense of when people would have gotten BCG. When obviously PPD can't be found or PPD is not available. People who are at high risk of not returning for the read or where TST is contraindicated. So people had a cutaneous reaction that wasn't TB related to a TB skin test in the past. When to do a TST followed by an IGRA? Well, if you're really high risk and negative at high risk of progression, and so, for example, in our organ transplant program, if we were to see someone from a very endemic area of the world have a negative TB skin test, we may want to do an IGRA on top, especially if they're already immunocompromised or on dialysis going into their setting, because again, you may not really bank on that TST being the perfect test. And the opposite, if you had a TST you did, someone that has 0 risk factors, it's positive, you're a bit puzzled, and maybe there's some sort of cutaneous reaction or cross-reactivity. Occasionally we can see even other mycobacterial antigens cross-reacting. You can use the IGRA to help as the rule-out test at that point. Next slide. So what to do with positive? So as I said, it's not a good test for active TB, but at the same time, if you do have a positive test, you should probably evaluate that person for active TB. And so just screening for constitutional symptoms, cough, hemoptysis, or any other odd symptom the patient's having. It's not going to be perfect. There are extrapulmonary TB syndromes where you can't screen for some of the things. But again, just anything in the medical history that's abnormal. And then a chest x-ray just to document that there's no active TB changes, particularly looking at the upper lobes. If you truly have a negative active TB workup, think about the risks and benefits, and generally where the benefits outweigh the risk. But again, it's a very patient-centered decision. And the regimens are here. So rifampin for 4 months, INH times 9 months. There is actually a really unique regimen that's INH and rifapentine weekly for 3 months. This isn't available widely in Canada, but there are some high-risk clinics through public health that may be able to do this with directly observed therapy. So maybe well for patients that are a bit more transient and have access to that. And so can talk to local public health units. And again, all of these medications, whether it's for latent or active TB, are funded by public health, but they do need to be reported to public health as part of that requirement for diagnosing latent TB. Next slide. So TST and 3D, which has actually been updated in the last year, is actually a really, really important resource as you go through this. And so this really gives you a definition of what people's risks are, what people's risk of adverse reactions are. And generally in people who are at low risk of progression, we can have a reasonable discussion in terms of what that means and their values around TB and TB risk reduction, and use that to guide the discussion. Most of these in low risk individuals is patient-centered, and we talk about risks and benefits, and I often leave it to patients. Obviously, if they're higher risk, we make a more benefit recommendation. But this is, for example, someone like myself who's 40, had a 10 millimeter test and didn't have an IGRA. And you can see, well, there's a 2.1% adverse event profile with using rifampin, but there is a risk of TB disease of about 0.5% in my next 20 years. This is death and disability from that TB infection of less than 0.1%. The use of therapy here would reduce my risk by 0.5%. So, sorry, 0.6% to 0.1% basically. And so, patients can kind of get the numbers and describing even 1,000 people what would happen, or using the happy faces, which sometimes can help make the argument. And again, for low risk individuals, as long as we monitor them, counsel for symptoms, and people who don't want to be on treatment, we just talk about monitoring and next steps. And some individuals who really do feel a risk benefit go on to do it. Next slide. So if you're suspecting active TB, so you go through this workup, or you have someone from an endemic setting with a persistent cough and hemoptysis, isolate them immediately. So on the next slide, we'll have some guidance in terms of what that means, and a little bit less strict than what we talked about with COVID back in the day, but still keeping them away from society. You can do sputums for AFB ×3. These are available through most labs. Best morning if possible. Working with public health can certainly help with these as well as part of the workup. But getting those through even Life Labs to the Toronto Public or to Public Health Lab helps with getting to the diagnosis. If they have extrapulmonary, so for example, lymph node or something like that, they need a biopsy of the site. So again, referring them to an individual that can do that. And for the most part, outside of certain settings, especially in the outpatient setting, we do not give TB therapy empirically. And that really is based on trying to get a microbiologic diagnosis for most individuals. And this is not a Canadian, it's a World Health Organization standard about treating tuberculosis, given that we often have to give patients significant drug exposure with toxicity and really do want to correlate to a positive test with better and better testing. The other thing is, for example, you have someone coming in, they're from an endemic area of the world, they've had a persistent cough, you want to give them a trial of antibiotic therapy, which is totally reasonable. Avoid using quinolones. Quinolones are actually treatment for tuberculosis. They're actually one of the first line drugs, not used in the typical form, but are an alternative. And so if you give them a quinolone, you may actually suppress the burden enough that their testing becomes negative, but still they have TB. And so really, think of beta-beta lactamase inhibitors. If you're thinking about Legionella, think about perhaps using doxycycline in that setting. But really avoid the quinolones in that setting because they can cause the workup to be negative. Next slide. And this is just from Toronto, the tips for home isolation for people that are going through the workup or who have active TB. And so, get family to buy food. You can walk outside, but stay away from other people, just given that the ventilation is incredibly good outside. Wear a mask when going to do TB testing, talk to public health about other appointments. Again, wear a mask and identify otherwise. In terms of who's in the house, the reality is individuals who live in a house who have active TB have probably exposed their household by the time the TB is there. It takes months for people to become symptomatic and even longer before people present to care. Outside of visitors, in most settings, people don't necessarily have to wear a mask around their individual family members. Again, recognizing that they've likely been exposed at that point, and that months of exposure are probably more than the 1 or 2 weeks to the diagnostic workup. Next slide. And I think that's it. Happy to answer questions.
Great. Thanks so much, Zain, for taking us through that. Really love that way of checking induration using the pen tip. That's not something I've heard before, and it often is challenging with your finger to figure out the induration. So thanks for that in particular. Few questions that have come up. So first of all, a question here, what if the test has been done two-step? I guess a two-step test was done years ago and was negative. And then their form comes in, requires testing again. Do we still do the two-step or refuse and only do the one-step?
Yeah, and I saw a comment on this, but a two-step is the first time someone is tested, you do a two-step. And realistically, if they have no significant TB, if it's 25 years later, fine, you could do a two-step again because they may have some exposures that are archived. But if you're doing serial testing, within a couple of years, then really that first two-step is what matters. And then the rest is one step because, again, their response should not, you've woken up the response if it's there for the second stage. And so every test there afterwards, you can just interpret it on the first stage because the response should be awake still.
Right. Okay, great. So we should be able to write back and say they don't need two steps at this point. They only need one. Another question, can you comment on a positive two-step TB test in someone who had BCG vaccination in the 50s in the UK? Should you continue to test as per protocol or do a chest x-ray, or is there another approach?
So I mean, the BCG issue is important, right? So again, as I said, anyone who's over 10 years of age who had BCG less than a year of age, their BCG shouldn't count towards their positive TB skin test. So that could still be considered active TB in the right individual. And so in that individual, yes, you can do your TST and 3D discussion. You can talk about monitoring and chest X-ray, look at their health status, obviously, and if they're starting to develop conditions that put them at higher risk, make sure that's assessed. If it's someone who got BCG later in life, you might want to do the IGRA to say, okay, is this real, or are we just testing your BCG over time? And that may help prognosticate that patient if they have the $100. But generally, if they have latent TB, then you have the risk and benefit discussion, and if you don't consider treatment, you just do the monitoring. I wouldn't necessarily do serial chest X-rays unless there's some change. But employers may have some different rules, but just monitoring for signs and symptoms more than anything else.
Okay. Thanks, Zain. And I think, unfortunately, the answer to this question might be no, but is IGRA covered in any circumstance by OHIP?
No, not that I know of. Again, there are rumors that there may be certain contexts where it will be covered, but for now, I don't know of a single context. We occasionally do them in hospital for inpatients where it's very challenging, but again, that's not OHIP covered. It's still kind of a hospital-based cost, so it's still a process.
Great, thanks, Zain. One last question on TB testing. What's the recommendation for intradermal TB testing for immunocompromised individuals or those with prior stem cell transplants? Is there a risk to these patients, and should we be using the blood testing in place?
So there's no risk, especially if they've had no positive tests in the past. If you have access to an IGRA, then maybe it's better in that context. If you're going through a TB workup for that individual, say they're going through employment or whatever, just recognizing that that's more sensitive in this setting. If you don't have access to IGRA, they can't afford it. There's still no harm in doing the TST and using the 5 to 10 millimeter cutoff. Some of my colleagues would actually recommend doing that first, because if you do get the 5 millimeter test, it saves them from doing the IGRA anyways, and is much more cheap and right at the bedside. But if they have the money to pay for it, then the IGRA may be better in that setting. But unless someone's actually had a significant cutaneous reaction to TB antigen, there's not really a contraindication doing it in that setting. It's antigen, it's not live bacilli.
Great, thanks. And actually, just on the topic of contraindications, what are the most common ones that you come across with respect to the TST?
Yeah, it's that large kind of TST response in the past, or anaphylaxis to an element, although there's not much in the TST that other than the purified protein antigens. But yeah, really, we've had these individuals, they're probably TB negative, but they just have a large, almost type 1 or type 2 reaction to TB antigen that is often sometimes has skin effects that are more long-term. And so, in those individuals, we avoid doing any further TB testing in the future. Obviously, if they've had a positive TB skin test, you don't want to do it again because it's going to be positive as well.
Great, thanks very much. There's a question about, is there a link to the TST in 3 days? We can certainly post that. It'll be in our resource list for sure. The other thing you had mentioned was the BCG Atlas, which I haven't heard of before. Just wondering if you could comment on that.
Yeah. So, it's obviously confusing. Everyone says they think they had BCG. You look at their arm, they may have the former scar. So BCG Atlas is from the same folks, Dick Menzies group in McGill, that have really just gone to countries, looked at their policy for BCG over time when they instituted them. And so it is a nice resource to say, well, this person grew up in Slovenia in the 1980s. What was their policy at the time? So you have something pretty objective to say, well, they probably got it at birth. And the vast majority of countries do give it at birth. But yeah, that you have something kind of to back that up, basically.
Okay, great. Thanks. We're going to turn over in a moment to Mark, but I just want to acknowledge there's quite a few questions around COVID vaccines that are not available now, I think, until the fall. And I'm not sure whether this is something that you could speak to. We usually have Dan on, but just to all our attendees, we have to give Dan a break every now and then. He will be back in September, and we do have a session the first week of September, which will be our preparation for the fall. So if you don't have an answer to this question, we can certainly bring it back to Dan in September.
I think the one thing I could say, so I've heard the same thing, that vaccine availability has not been great. The one thing I'll say is that and I'm sure it's gone through one of these sessions, is that the NACI's recommendations for who gets 2 doses a year versus 1 dose a year have changed. So it is, largely 80 immunocompromised and living in institutional settings that are 2-dose candidates, and kind of a discretionary recommendation for 65 to 79. And so, those groups that are 80 plus immunocompromised and congregate settings should be getting it. But other populations less. That being said, hopefully you can find it for those folks. I know it's difficult, but just as you're making the recommendations, make sure that those patients are really there. It's a little bit different than years prior, where it was just everyone over 65. It's really becoming tight in terms of who needs the second dose kind of a year and who needs the 1 dose a year type thing.
Great, thanks very much, Zain. There's a couple of questions still left in the Q&A, but maybe you can take a peek at them. We're gonna, as it's 8:30, we're gonna turn things over now to Mark.
Great, thanks, and thanks for having me here to be able to speak to you this morning. So when I got asked to do this, it was specifically around the question of physician pension plans, and I've been getting asked about that a lot recently because MD Financial and Scotia have their Medicus pension that they've been advertising quite heavily, and Hoop has also come out with an option that physicians who are incorporated can buy into as well. That's also been getting a lot of press time. So I was asked specifically to speak a bit about that. I have nothing to do with selling either of those products, but I think it's important to talk a bit about how they fit in potentially to the rest of your retirement planning, because it's just actually one piece. And when you buy into a pension, it means you're also giving something else up. Next slide. So I just want to start off by saying that, retirement planning in general is actually a lot more complicated and a lot more, there's a lot more important aspects than just the products and the accounts and the financial strategies. So I think that gets a lot of emphasis, and it's usually where people start asking questions like for this talk. But there's multiple components you really need to think about. There's the product aspect where you're using stocks and bonds to invest, or funds to do that in a diversified way. Pensions or sometimes life insurance gets sold for that purpose, even though it may not be the best option. There's also, where do you put those investments? Do you have tax-free savings accounts and RRSPs? You might use a pension plan. You may have a lower income spouse who could do some investing, and you have your corporation, which may do some investing. But you also have to consider some of the other aspects for successful retirement. These I think are particularly important for physicians. And one of those is the human capital aspect of it. So you have to be able to develop some interests outside of medicine, some work on your non-work relationships, and looked after your own physical, mental health. If you don't do that, you're going to have a difficult time retiring. And that's where I see physicians often fail or have not the retirement they wanted to, is because they didn't have those outside interests, didn't have those outside relationships. Everything was centered around work and medicine, and it's hard for them to transition to something else, or they are forced into retirement due to health issues and struggle with that. And the final part I'd say about managing that non-financial part is to give both of your time and your money while you're alive, rather than building this giant nest egg, not spending it during your retirement, and then it's there when after you've passed away, when you could have actually done that, used it while you're alive, to even if it's giving to others to see how it's used and enjoy that. And I think the other aspect that hits us as physicians whenever we're thinking about retirement is, what's going to happen to our patients, and how do we plan for that transition to the next healthcare provider. So I can't talk about all of those issues today. I am going to focus back onto the pension piece, which is just one small part of retirement planning. But I just wanted to mention that it's broader than that. And like everything else with investing, the sooner you start doing it, the more you can benefit from compounding over your career. And you have to plan this stuff in advance. Next slide. So when it comes to the financial piece, one thing to be aware of with pensions is that they're actually just one small part of the different pots of money that you're going to draw from for during retirement. We get several pots that we pay into that we're going to get income from that we don't really have a lot of control over. So Canada Pension Plan, Old Age Security is one of them. If you're using an RRSP, then that converts over to what's called an RRIF, or retirement income fund, that you draw money from during retirement, and you have to do it at a certain rate. If you're paid into a pension, then the pension pays you. You don't control when it pays you and flex it up and down. It's actually determined by the pension. And if you are incorporated, even though corporations technically can choose what they pay out, if you don't keep dividend income flowing out of the corporation each year, the corporation becomes quite tax inefficient. So you're forced to take income from your corporation every year if you're incorporated. You may, as one add, not only to address the financial aspect, but also that transition to some casual work that brings in income. And then you have a variety of other accounts that are going to be part of your planning. You may have personal investment accounts. There's different ways that you can pay money out of your corporation with different tax consequences. And you can also, if you're using an RRSP or a TFSA, elect to take money from those at different times additionally as well. Next slide. So when we're talking about all of those different options that I just mentioned, being incorporated does open up more doors for people. That does not mean that I would just go and incorporate just so that I can access more options. Incorporation has to make sense for other reasons. If you're not incorporated and you're collecting income, you're going to pay into the Canada Pension Plan. You're going to get RRSP room, which an RRSP is very pension-like tax-wise, and a lot of the regulations are almost identical. And using an RRSP and a pension is kind of a decision because it's almost one or the other. If you contribute to one, it takes away from the other. Now, if you are incorporated, in addition to those options, well, one, you can leave extra money in the corporation and then take it out as dividends in retirement. Yes, that it's not quite as cost effective as using registered accounts, which is what everybody else will be using. If you're paying yourself salary, you're also going to be paying into Canada Pension Plan like everybody else. You're going to generate RRSP room. But the two big options that are available to corporations that aren't available to people who aren't incorporated are buying into pension plans. And there's two big types, which we'll talk about, which are the individual pension plan, or an IPP, and a multi-employer pension plan, or an MEPP. And that's where things like Medicus and HOOP fall into. Next slide. So just one of the things I want to address up front is people figure, there's a very common piece of advice that people get: just keep everything in your corporation, don't bother with RSPs, don't bother with anything else. Corporation's the best thing on the planet. That's probably not good advice. And just to look at that from a very simple standpoint, if you're using an RRSP or a pension, the money when you put into it, an RRSP or a pension, is basically pre-tax. So when you put money into the RRSP or the pension, there's no corporate tax paid on that. There's no personal tax paid on that. It leaves you a larger pot of money to start with to then grow for the future. So you have a bigger pot to start with. As it grows tax-free as well. So there's not tax every year. There is tax when you take the money out in the future. And when you take it out in the future, yes, you have to take out a certain amount each year. If it's an RRSP, there's a minimum that you have to take out. It's actually very small, and it rises as you get older because the intention is that you are forced to take money out of your RRSP before you die. And with a pension, of course, if you're using a defined benefit pension, it's going to pay you amount each year. You don't really control that. Now, in contrast, a corporation is not 100% tax deferral. It means that when you do big money in a corporation, you pay the business tax on it. Whereas with an RSP or pension, there is no tax. So you start off with more money than you would individually to invest, but it's not as much as an RSP or a pension. And when you earn investment income in a corporation, it's taxed each year. So it's not tax-free growth that's all deferred to the future like it is with an RSP or a pension. And down the road, yes, you do have to take money out of your corporation, or it's going to become very tax inefficient. So the notion that corporations are better for taxes and in retirement is probably not true. Pensions and RSPs have better tax advantages. Next slide. So just to hone in on the pension options. So I mentioned these before. There's the IPP and there's MEPPs. And the big difference between the two One of them is that an IPP is a pension that a single corporation opens up. So your professional corporation can open an IPP that would provide a pension for you, potentially a spouse, but it's meant for a very small number of people with one corporation. A multi-employer pension plan is kind of what it sounds like. Multiple corporations, which would include your own, buy into this big group plan. And the advantage of that is that you pool the risk management and you pool the investing with other corporations, where with an IPP, it's all with your corporation. Both these types of pensions tend to be defined benefit. Yes, you could have a defined contribution version, but there's really no advantage of that. So it's a defined benefit, which means you pay into the plan and you should get a certain amount of money per year when you retire. Now, one of the big differences is that with an individual pension plan, how much you can put into that pension is quite variable. And it's variable in what's usually an advantageous way for your corporation. So I mentioned that corporations are exposed to tax. It's not 100% tax deferral, whereas pensions are. So the more money you could shift from a corporation into a pension, the more advantageous it is. And with an IPP, as you increase in age, the amount you can put in there after around the age of 40 becomes more than you could put into an RRSP. So it's a way of shifting more money from a corporation into a tax sheltered pension. There's other variables there as well, like how the investments you have perform. It gets quite complicated, but the main point is that you can start to tax shelter more money than you would otherwise. Now, with the multi-employer pension plan, it's a fixed contribution, and the amount you're allowed to put in is basically the same as you can put into an RRSP. So it doesn't grow as you increase with age. So it's very similar to an RRSP. And when you contribute to a multi-employer pension plan or an IPP, the thing to be aware of is there's that something called the pension adjustment, which means that that amount you put into the pension, you can't put that into an RRSP. When you give into one, you're taking away from your room for another. Now, with these pensions, what happens depends on how the investments perform. So, the pensions will say you're going to get us, you pay us a certain amount of money, you're going to get a certain amount of money in retirement. It's not 100% guaranteed. I mean, it should be pretty certain, but it's not 100% guaranteed. It depends on the investment performance. Now, with an individual pension plan, because your corporation's taking all of the investment risk, if the investments are doing really well, then your corporation may have to take a contribution holiday, and not put extra into it, which is something you don't really want to have because you're trying to put more money into that tax shelter. If the investments are underperforming, and that could happen on purpose, if you have low risk, low return investments put into the pension, then the corporation can shift even more money into that tax shelter. Now, what happens with the multi-employer pension plan is different because the amount you can put in is fixed, but if it's overfunded, then they have some levers they can pull. They can give you an inflationary increase to your benefit each year, as long as it's well funded. If it gets underfunded, then the pension managers are in a very uncomfortable position where they have to either reduce the benefits or increase the amount that the participants have to contribute to the pension. Next slide. So that's a lot of technical information. One of the big things is, okay, what's the difference between an RRSP and a pension? Because that's one of the things that you're generally deciding. Again, when you contribute to one, you're taking away from the other. So one of the advantages of both these is pension splitting. So if you get income from either your RIF or your pension, and you have a lower income spouse, you can attribute some of that income to them so that it gets taxed in lower tax brackets. Now, with an RRIF, which is what an RRSP becomes, that you're allowed to do that for the age of 65. With a pension, you're allowed to do that after the age of 55. So pensions have a slight advantage in allowing pension splitting earlier. That said, one of the things that the pension providers touting that don't mention is that you could use a spousal RRSP where you contribute to an RRSP that's going to be owned by your spouse, which they can actually access that money at any age as a way of splitting your income out. The withdrawal with an RRIF or an RSP, you have a lot more flexibility. So you do have to take a minimum amount out each year. It's usually a few percent. But if let's say you have something extra you want to fund, you can take extra out of your RRIF without too much of a consequence. Whereas if you're in a pension, you get the pension benefit that's paid out. You don't get to flex it up and down whenever you feel like. So pensions have less withdrawal flexibility. And the other thing that's mentioned is creditor protection. So if you go bankrupt, pensions are fully protected from creditors. RRSPs are generally protected from creditors, although if you put a contribution in and someone goes after the money in a very short period of time after that, it may not be. So you can't, when you're going bankrupt, shove a bunch of money in your RRSP to protect it. That's why that law is there. And then when you're taking it out in retirement as an RIF, it's protected from creditors. Next slide. And then the other question that comes up to consider is what happens to the money you've put in there when you die. So with an RRSP, if you die, well, we all die, but if you die and you have a spouse or a dependent offspring that have disability, the pension, the RSP could actually be rolled over to them, usually into their own RSP or RIF. And if it's a disabled offspring, then it could go into what's called a registered disability savings plan. But the point is, it can continue being tax deferred and tax sheltered until the second person dies, at which point it becomes part of their estate. But the money stays that you put in. If there's excess money, it stays with your own wealth. With the IPP, the individual pension plan, if you die early, or your spouse could have a spousal benefit from it, or they could put that money, some of it at least, into their RSP. Some of it might have to be paid out if there's too much of it. And of course, after the second person dies, then it becomes part of the corporation's estate, which then is dispersed. Or you can also name a beneficiary and bypass some of the complexities of what happens to your corporation when you die. Now, with the pensions that are group pensions that you buy into, when you die, the money stays with the group unless they decide to pay it out to you. And so if you die before retiring, they will value how much you put in there, and they will commute that, which means they'll value what's in there and then pay out what the value that they've determined to be of your contributions is. And that can go potentially to a spouse and their RSP, just like it could with your regular RSP. Or they could continue inside the pension plan and get a spousal benefit. Now, let's say you do retire and you die pretty early after retiring, and so you haven't really collected a lot of benefits. The pensions will pay out some benefits for a certain period of time as a lump sum. So let's say you retire and you die 2 years after retiring, they may pay out 8 more years or 13 more years of benefits, but you still, with the rest of the money that's left after that, stays within the pension plan. So one of the things about a group pension is if you are someone who has a shorter life expectancy, you die early, your contributions are going to help to fund the people that live a longer period of time. Next slide. So just to summarize that at a high level, if you want to compare the options, RSPs are more flexibility. It comes at a lower cost. IPPs, there's the potential to shelter much more money from your corporation into the tax sheltered pension, but that depends on a whole bunch of factors. And when you do that, you're also introducing costs and complexities, and there's more rules to follow. So it doesn't make sense for everybody. It's not a slam dunk. With the multi-employer pension plan, it's easy, it's predictable, you're sharing risks with other people, but that comes at a cost too, because you're putting money into that pot to be managed as a group, and when you die, that money, most of it's going to probably stay with the pension plan to fund the other members, unless you live for a really long time. Next slide. So when I'm thinking about this, there's a few big questions I'd ask myself. Next slide. So one of the nice things about a pension is that it pays you a certain amount of money each month, and that doesn't really fluctuate. You don't see the market's going up and down. Whereas if you have an RRSP or an IPP, you're going to see your investments go up and down in value. And if you're someone who finds it psychologically soothing to see just a regular paycheck coming in, and you know that's what you have, that's what you're going to spend, that favors having a group multi-employer pension. If you're someone who, with your portfolio is doing really well, you have no problems splurging a bit in some way, or if your portfolio is pulled back and you're concerned about it, you might, delay some spending, then you can tolerate some of the fluctuations of an RRSP or an IPP, and it might be more towards that side. It's not a cut and dry answer. Next slide. One of the advantages of an MEPP is that if you're someone who really prefers to be hands off with your investments, so you're either going to not do it on your own, or you're going to pay someone to do it. It's particularly if you're paying high fees or you're a conservative investor, you're not going to have very high returns. Well, you're not probably sacrificing too much by putting the money into a multi-employer pension plan, letting them invest it, getting the benefits of scale that they have investing, and the way that they can invest might even be more aggressive than you would as an individual. So if that's the case, that favors a multi-employer pension plan. On the other end of the spectrum, if you're someone who either wants to be involved with your investments, or you have someone doing it, but you have more than enough buffer and you are invested in a fairly aggressive way with relatively low costs, so you're getting good returns, then that might favor keeping those returns for yourself rather than putting them into a pot with a bunch of other people. Next slide. And the final point I'd make with the pensions again is longevity. So if you're someone who has a lot of longevity in your family, and you're someone who you're thinking about, you're kind of in that middle about whether buying into one of the group pensions or not makes sense or not, the people that live longer tend to benefit more than those who die early. Next slide. Great. So I've tried to just give a quick overview, crammed into what is a relatively short period of time about pensions. The main point that I want to make is that they're one option out of many options that you'd have to consider. And when you decide to go with a pension plan that you're buying into, there's other sacrifices of other options that you're making. So you really want to weigh those options against each other. So I go into some of the more details of the mechanics and some of the numbers in a number of posts on the Looney Doctor blog. So there's a pension basics for self-employed professionals, which is probably where I'd start, where I go through a lot of terminology and all the little letters and acronyms and stuff. I did write it about whether you should consider weighing a group pension plan versus your RRSP or an IPP as an option. And then I also get into some of the numbers and mechanics of Medicus and Hoop in another post. On the Money Scope podcast, we've just recently recorded an episode which goes into a very detailed deep dive about all these pension options. We've recorded it. It should be coming out soon. And with that, I'll just finish there to try to answer any questions that I can.
Great. Thanks very much, Mark, for taking us through that so clearly. I think the biggest question that's come up is for those folks that are pretty close to retirement. So, 4 or 5 years from retirement, should I still be considering pension plans, and would there be any benefit?
Yeah, so you could. So again, the questions I would be asking myself come down to the same questions that I just mentioned. So a pension, paying into the pension plan may or may not make sense. If it does make sense as you get close to retirement, it is still an option. You can do what's called a pension buyback. So they'll allow you to buy back previous years of service. Now that doesn't come for free. You're buying it back with the cost, and the money to do that will come first from your RRSP, and if you don't have enough money in your RRSP to fund it, then it gets topped up by your corporation. So it's not something I would want to do necessarily if a pension didn't make sense for me, but if it did make sense for me, there are ways to go back and buy previous service if you're close to retirement. But again, whether a pension makes sense for you and whether it's something you want to do is the first question that I would ask.
Great, thanks. And you usually use those sort of criteria that you went through, or those questions to ask yourself in terms of thinking about whether to have a pension or not.
Yeah.
Another question for you, actually, this is on whole life insurance. So what are your thoughts on participating in whole life insurance?
Yeah, I figured that would come up. A lot of people have been sold whole life insurance over the years. It's marketed quite heavily. It gets sold with the premise that, well, that's great because it gives you tax-free payment when you die. So it's a way to avoid taxes, and you can borrow against it and access the money in retirement. Now, the problem again with that is it's not being compared to what are the other options that you're giving up by putting money into it. So if you have $10,000 to put into whole life, or if you have $10,000 to invest any way you want. So if you look at it that way, whole life insurance it has a return that's closer to fixed income. So when you count for the taxes, if you would otherwise take that $10,000 and invest it in bonds, then the whole life insurance on an after-tax basis might do a little bit better than the bonds would. If you were to take that money and invest it in equities or stocks and have a relatively low cost way of doing that, that's likely to outperform what you'd have with permanent life insurance, even though you pay taxes when you realize the capital gains. Yes, you pay more tax, but you also have more money even after you've paid the tax. So that's the one issue. So you have to compare it to how you'd otherwise invest. The other problem is that to access that money while you're alive, you have to borrow against it, which means you're going to start paying interest. There's going to be other fees involved, and you made your life more complex. Whereas if you've used just regular stocks and bonds or funds and you need money, you just access the income that comes out or sell some and access that and move some of it out as a capital gain, which you can do very efficiently from a corporation anyways. Uh, so if you look at that, it's probably not a big advantage to doing it. It's probably a disadvantage for most people. But again, it's situation specific. Depends what you otherwise do with the money. The big use I can see for it is if you're willing to pay a little bit extra to cover the tax bill when you die because you have something to pass on to your family that's hard to sell, like say a family business or a big chunk of real estate, you can't just turn around and sell it at a bad time. Then covering the tax bill with some whole life insurance could make sense. Or if you are accepting the fact you don't want that money while you're alive, you don't want to access it in any way, and you'd otherwise be putting it in a low return investment, then it could make sense from that standpoint too. But those two situations are probably not most physicians.
Great, thanks for clarifying that. A couple of questions around the IPP. First of all, I'll ask you both of them. What is the latest age that you can start one? And also, how do you actually set one up? Someone mentions they have MD management, manage their investments. So they're wondering about how you go about the process of doing it.
Yeah, so you can contribute to the IPP to any age you want. So just like with the other pensions, if you decide to do it closer to retirement, then you can do a pension buyback. And that's actually with an IPP, that is actually an advantage because what you can usually do is when they do the calculations, you can put some money from your RRSP and from your corporation and put it into the IPP. And if you started it a bit later, the amount you can put in is usually more, and you haven't had all those years leading up to it where you've been paying the costs of managing the IPP on top of it. So it's doable at any age. That said, you don't want to do an IPP when you're too young because there's costs to running the IPP. You have to pay an actuarial fee, and then there's the cost of the investments. And the big advantages happen when you're over the age of around 40 on average. It's an actuarial thing, so I can't give you a cut and dry number, but generally over the age of 40, just the way the calculations are made is when it could start to make sense. And if it does make sense later on, you can do it later on close to retirement. And there's ways to do that. In terms of how it's done, you pay an actuarial company that would come up that does the paperwork and comes up with how much you can put in. If you're using a financial advisor, they should be liaising with the actuarial company, whichever one they use to do that. And then the investing piece is basically just an account that you can invest it like you would normally. There's a few rules, but they're really not a big deal. And they do it that way. So it would be work between your financial advisor and an actuarial firm to do it.
Thanks very much, Mark. Very quick question before we just finish off our slides, and then we'll come back with a few other questions. But I just wanted to get this one in because there was a note in the chat in terms of when there's only the moneyscope.ca, your last episode they could find was from November 2024. Is that the most recent one?
We did do, I think so. Yeah,
Okay,
we're slow to turn them out because we do a lot of research to write them. So maybe it's 18. That's the next episode that's coming. We've recorded it. It's about IPPs and other pension options. We mentioned MEPPs as well. And then we're going to follow it up with a case episode as well, but give some examples of when different options make sense and when they don't make sense. So it's
okay.
cooking.
So people can stay tuned for that.
Yeah.
Maybe Susan, can we just bring the slides up? We'll come back with finish off a few other questions, but just for those that really have to dive off for 9 a.m. Just a reminder that there are other communities of practice, including the mental health addictions and chronic pain, and they have a really interesting couple of sessions coming up in July and August. And also the Peer Connect mentorship is a wonderful program that you can connect to for receiving help with patients that are challenging within your practice with substance use and chronic pain disorders. Next slide, please. Just a reminder, all our sessions are available online. As we mentioned, you can do them as a self-learning. These are some of the ones that we had coming up recently, and our next session is going to be in September. Next slide, please. So September 5th is our next one, and at that point, hopefully we can answer some of the questions regarding COVID vaccines. We'll have Dan back on for that. And for those of you that are signing off now, I hope everybody has a wonderful summer, or already is, and hopefully has some time to relax over the upcoming month. And with that, we'll just take the slides down, and then we'll turn back to just finish off a few more questions. Okay, so just back to a couple of other questions regarding the pension plan. So one comment that came up was regarding, are you aware of any MEPPs for unincorporated physicians and their families?
No, yeah, you have to be incorporated to buy into an MEPP. So
Okay.
it has to be a company that buys into it.
That's straightforward. Can you please review, is there an income threshold below which incorporation is not useful? It says until retirement.
Yeah, so it depends a lot on your spending. So you basically have to spend quite a bit less than what you make for a corporation to make sense. So if you look at the different options you have, a tax-free savings account and an RRSP, both are tax sheltered, more tax efficient than a corporation. So if you're filling up your TFSA, filling up your RSP, covering your costs of living, and you still have a bunch of money left over, that's when a corporation becomes the question about whether because it doesn't make more sense to invest through the corporation that you make or just to invest personally. So if I were to generally say, people that the maximum RSP contribution room generation is around $185,000 a year. So if you have an income below that, generally incorporation wouldn't make sense because you can use your RRSP and your TFSA. That said, there are other reasons to incorporate, like if you're smoothing your income because it fluctuates up and down a lot each year. If there are liability issues, which it doesn't really apply to physicians because professional corporations don't really protect us from that. But it really comes down to you have to be making enough and spending a small enough amount of money that you can max out your tax shelters and have money left over to invest. The
Great.
short answer.
Yeah, great. Thanks very much for clarifying that. Couple of other quick questions. Are contributions to RSP or pensions plans made through the corporation account or our own personal account?
Yeah, so a pension is contributed directly by the corporation. An RRSP, technically you're paying yourself income, and then it goes from you to the RSP. You can pay directly to an RSP from a corporation. There are ways to do that, but it actually doesn't matter because with a pension, it's a deduction against corporate income, so there's no corporate tax on it. With an RRSP, if you paid salary, that's an expense against the corporation, so there's no corporate tax, and then you deduct it against your personal income, so there's no personal tax either. So whether it's paid from the corporation or through you to the fund, it actually doesn't matter from a tax perspective, and it can be done directly from the corporation for either. Although with an RSP, it gets a little bit more finagly with the paperwork.
Okay, that's good to understand better. Question here about what about the Canadian Physicians Pension Plan Corporation?
Yeah, so what that is it's a personal pension plan, which is a brand name version of IPPs. So essentially, it's like an IPP, and what you do when you're paying into that is that they're opening an IPP or a PPP for your corporation, and they're also managing it. So you're paying them to do the investment management and to have the PPP, which is it's a branded version of an IPP. So you'd want to ask yourself, one, does it make sense to have an IPP or PPP? That's the first question. And the second question to ask is, do I believe and like the way that they manage their investments? Because you're trusting them to manage your investments.
Great, thanks very much for that. One question here, how does a person over 70 find out why they're not receiving CPP? Do you know the answer to that?
Yeah, I think you have to actually apply to start taking it. So you'd have to. I don't know the mechanics myself, but I think there's a way that you have to apply through Revenue Canada to actually receive it.
Great.
It doesn't happen automatically.
Okay, that's good to know. And then somebody was just hoping you could explain again what happens with an MEPP if you die but your spouse or your husband is still living. What would he get?
Yeah, so if it happens before you retire, then they value the amount you've contributed to the pension, so they value it and then commute it. So the amount of money that comes out could go, if before you die, could go to them, which usually there's a way to roll that over to their RRSP. And if there's some excess, then they'd have to it would come out as income, but usually it could go to their RRSP. With Hoop, there's also the option for them to stay in the pension plan, and when they do retire, collect a spousal benefit rather than commuting the pension. So you have the option to keep it there. If it happens after you die, you can pay. Well, you can have a spousal benefit, which to do that, you basically take a lower baseline benefit. So you're essentially paying for it by taking a lower baseline benefit. But when you die, your spouse continues to collect a benefit of some proportion of what your pension would have been. If you don't opt for that benefit, or you don't have a spouse, then it depends on if you die early in retirement, some of the residual amount of money up to a certain time period gets paid to your estate.
Great, thanks very much. A question regarding if you have an IPP and have retired and are drawing a pension from the IPP, what happens if there's a pension shortfall and the corporation doesn't have available funds to make up the difference?
Yeah, then the benefits are going to have to be reduced. Yeah. Yeah, so when you do an IPP, you are taking more of that risk of your own investments, right? If your own investments outperform, it's great. You end up having a big pot of money, and even if you don't use it with the benefits before you die, it goes back to your corporation and filters through back to your family or donation or whatever you decide to do. If it has a shortfall, then you have to decide which levers to pull. Either the corporation has to put more money into the pension, which would be the default usually, and if it's unable to do that, then there's going to have to be some adjustment with the benefits.
Great, thanks for clarifying that. Another question actually just around the CPP. Does everyone get the CPP or only selected people who have contributed towards it?
Yeah, only if you've contributed towards it. So Canada Pension Plan is actually its defined benefit pension. It's indexed to inflation, has a death benefit. It's actually a really good pension. You pay into it automatically when you pay salary to yourself through your corporation, or if you collect T4 income from other sources, you automatically have to pay into it up to the thresholds. Even when you account for the fact that as an incorporated business owner or self-employed, you pay both the employer and the employee side of it, it actually tends to be a good deal compared to other comparators because it's a relatively safe income stream indexed to inflation. You can't even buy that on your own, but if you could, that relatively safe investment is unlikely to have the same return as your CPP contributions. Now people go, well, yeah, if I were to take that money and invest it all in equity in my corporation, I'd end up with more money. Yeah, that could happen because you're taking more investment risk. But if you compare it on an apples to apples basis, it's a pretty decent investment. But you have to be paying salary to yourself or getting T4 income from some source to pay into it.
Great, thanks for clarifying that. Just could you clarify just in terms of a contribution to either the IPP or the MEPP, is it tax deductible?
Yeah, so it is whether it's an RRSP or an MEPP or an IPP, they're all basically pre-tax, which means it's deducted. The amount that's put in is deducted against income, so there's no tax on it. So whether it's an MEPP or an IPP or you putting money in your RRSP, all of them are there's no tax on that because of the deduction. You do pay tax when the income comes out or the money comes out in retirement, hopefully at a lower tax bracket.
Right, excellent. And then this question from testamentary point of view, apologies on that. Is IPP better than any other form of savings? I think you talked a little bit about the different ways you would make a decision around whether to get an IPP or
Yeah, I don't think
MEPP
I
or
can
not.
give a canned answer on that one. There's just too much variability involved there.
Absolutely. And one last question, if you're able to address this, although I think this could be another topic, is critical care illness insurance. When is this useful and at what age?
Yeah, so critical illness insurance is basically if you get one of a defined list of terrible things, which we all have that list, then it pays out money. So the question is, insurance is meant to pay for things that you are rare but catastrophic that you otherwise couldn't pay for. So the alternative to critical illness insurance would be to have enough financial buffer that you either have an emergency fund or you have money invested in other ways that you could access should one of those nasty things happen to you. So if you don't have emergency fund or a buffer or investments to draw on, then critical illness provides that safety net if you get one of those terrible diseases. Now you're not getting that for free. You're paying it into the insurance, and insurance companies know the odds. So if you think you're going to buy critical illness insurance and then be really lucky and get a terrible disease and get paid out, the odds are you're going to pay more into the critical illness than it's going to get paid out. So generally, if you don't need it, you might be better just having the money on your own. One of the ways they use to sell it is to say, well, if you don't use it, then we're going to give you your premiums back in the future. So after 20 years or whatever, we'll give you the premiums back. But what is not being said is that you actually pay more premiums to get that feature. And you also have to remember that getting, your money back 20 years from now, when you could have had that money invested on your own for 20 years, you're probably going to have a lot more money invested on your own for 20 years than having it sit in some policy. So the question to ask yourself is, do you need it or not? And if you have other ways of paying for critical illness and bad things that happen to you, then you may not need the insurance. If you don't, then you probably want the insurance.
Great, thanks very much, Mark. I think we're going to finish off there. That was the last of our questions for you. Really appreciate you taking us through this, what I find, I have to admit, a fairly complex area. So I hopefully the audience also had the benefit of you clarifying it for us in terms of pension plans and options when it comes to retirement. And also wanted to just thank Zain again for coming on and speaking with us about TB and answering those questions. I hope everybody has an absolutely wonderful summer, and we will be back in September. We take a break in August, but we'll be back in September with our update for the fall. Happy summer, everybody.